Hello, everyone, whatever time it is where you are, good afternoon, good evening, good morning. Welcome to the Youth Mental Health Equity Forum, hosted by Johns Hopkins Medicine, the Howard County Medical Center. And we have some amazing guests here today. We're going to talk about a subject that's very important to me. I'm so excited about this because I know how much I need to learn about this. And I know you do as well. So let's welcome our panelists. I'm Pastor Keith Battles, Zion Church. I'll be hosting today. And I'd like for each of our panelists to introduce themselves, starting with Corey. And then we'll go to Dr. Seidel, Dr. Swartz, and Dr. Reynolds in that order.
Hi, everybody. My name's Corey Bryce. I'm a certified peer recovery specialist with the Howard County Health Department. I'm 30 years old. I've had living experience with mental health and lived experience with substance use. Those experiences kind of inform the way that I do my work with people who are actively struggling or people who are in recovery. I've been able to work in lots of different environments, including jails, public school system, recovery housing, and street outreach.
Wow. You're a vet at 30.
Yes.
Corey, thanks so much for your work. Dr. Seidel?
Yes, so I'm Stacey Seidel. I'm one of the pediatricians in the emergency department at Howard County Medical Center. I've been in a community pediatric emergency center for the last 18 years. So my role is mostly taking care of both medical as well as emergency mental health problems. In terms of my personal experience, probably many close friends and family, seeing them through various mental health struggles.
Yes. And thank you for being that, not just in the community, but for your own family. Thank you for being that. Dr. Swartz, your personal experience with mental health or your professional experience, or both?
Well, I'm a psychiatrist at Johns Hopkins, and I have been focused on the treatment of people with mental health issues since 1991, when I finished med school at Hopkins. And so I did my residency, and I've been at Johns Hopkins this whole time. I mainly focus on individuals that are dealing with depression and bipolar disorder, but I've worked with people with all kinds of challenges. And as you can imagine, having depression sets you up for other challenges. So I have great respect for the individuals that are going through this, because it's hard, and for their families who support them. So I have a lot of admiration for both the individuals going through it and the families supporting them.
Well, Dr. Swartz, before I go to Dr. Reynolds, because you said this, having depression sets you up for other challenges. Mm-hmm. I got to go there. Can you just talk to us about that, our audience, about what other challenges accompany having depression?
So we know that if you have one major issue, depression or even severe anxiety, others, you're going to be at higher risk of also getting involved with substance use. You're going to have higher risk of having a second mental health condition like an eating disorder or an anxiety disorder. You're going to have higher risk of getting into self-injurious behaviors. And so, unfortunately, one challenge leads to many, and then that can just feel so overwhelming that, especially young people, I think that they just don't know how to get out. Earlier today, one of my patients said, I feel like I'm in a hole and I know I need to stop digging, but I just can't. Wow. And I think that's the point.
Wow. What an opening statement. Dr. Reynolds.
Hi there. Thanks for having me. I'm Elizabeth Reynolds. I'm a psychologist here at Johns Hopkins Hospital. I direct our pediatric psychology program and clinically focus on patients that are hospitalized here for a psychiatric reason. I've been doing this work for 15 years here at Hopkins, and really, I think what drives my passion for the work is helping the children and adolescents I work with be able to live full, complete lives, and really helping their families manage this challenging time.
Excellent. Dr. Reynolds, I want to stay with you for a second, because before we get into diagnosis and disorders, I want to talk about just the term pediatric and adolescents, because I heard that come up during your intros. What is that from an age standpoint? what is pediatric? What is adolescent? How old are they? What is the youngest age? Talk to me about just the age of children.
Yeah. So I think that's a really excellent question. Typically, we think about adolescence as starting at 12, right? Typically, we think of teenagers as 13, but really that adolescent period around 12, starting with puberty, going up through age 18. And then we start to think about this transitional age youth, right? 18 plus, right? These youth that are technically legally adults, but still need a lot of support. With pediatric, that's a term that can get applied really kind of broadly, right? Thinking about a broad age range, but I would say when we're saying child, I'm usually thinking of that 5 to 12 age range. And then under that, we could think about this, the preschool age, right? And so we do see some mental health challenges emerge as early as preschool. And usually we see that as kind of more disruptive behavior, anxiety that can present that early. Yeah.
That's very helpful. And you all are going to kill me because I'm going way off script, but it's just
okay.
So curious about this. So to Dr. Seidel, Dr. Swartz, or Dr. Reynolds, would you typically say that an adolescent or a child would be considered in the pediatric range, that their mental health experience is triggered by some form of trauma, or can it just be genetics, or does the question even make sense? Is there a ratio? I know that's not one of our topics today, but every time y'all say something, I think about something else that I want to understand because of the work that I do. And as I told you all before we got on here, in the community that I serve, we don't talk about this enough. And I'm grateful to bring it to my audience because we have to know what we don't know. So how would you answer the trigger? Is it triggered by trauma? Is it genetics? What's the backstory? Anybody?
I guess
I'd be happy to start, and then Karen, if you want to fill in too. Really, we think about it as both, right? So there are many complex risk factors for mental health disorders. So both a genetic predisposition can certainly be part of it, but also the surrounding environment and personal experiences. And as you talked about, traumatic experiences, right? Sometimes you might have some type of underlying predisposition, and then you're exposed to a traumatic experience. Also think it's really important to take into account like how children are living, things like poverty, food insecurity, homelessness, lack of access to healthcare, educational opportunities. These are all things that can really make a child at risk for difficulties.
Great.
And I wish I had the ratio of exactly what we know of genetic versus environment, but
every person, right?
It's a both and, right?
Yeah, it's a both and, but it's every person. For some person, it might be nearly all genetics. For another person, it could be completely coming out of the challenging life they've had. I think a big problem is that if someone is having incredible challenges, no one thinks that they might also have a medical problem. They look at their life and say, of course this child's suffering. Look at what he or she's dealing with. And they don't take a step back to say, has this triggered something else? An analogy I use when I'm working in high schools is asthma, because sometimes an asthma attack comes out of the blue, and sometimes it's triggered because you went to see your friend with 3 cats. And you treat it the same. You're looking to see if the person's having an asthma attack. You don't say, you're having cat asthma, no inhaler for you, just get over yourself. And I think we do that, right? It's like, oh my goodness, what's going on in your family and the divorce and the this and the that. You just need to accept life. And that's terrible because that is accepting suffering sometimes.
I think we also, one thing we see in the emergency department, I think trauma is different for every person. And sometimes there's things you don't think, there's a fairly typical, what you would classify as typical upbringing, but there may be significant trauma to the patient just because there may be cultural clashes between their family. They may not understand them. So I think trauma is different, and it's not always obvious trauma.
Yeah, great answer, ladies. I appreciate it. Let's talk about diagnosis and disorders. We're coming to you, Dr. Reynolds. Yeah. What are the most commonly seen mental health disorders, particularly amongst youth?
Now, amongst youth, the 3 most common categories are anxiety disorders, depression and behavior problems. So we think about anxiety disorders as characterized by excessive fear, worry, and then related behavior disturbances like avoiding. So avoiding things that make you feel anxious or worried. Depression characterized by sadness. And in children, we see a lot of irritability and really losing interest in the things that you used to enjoy. Behavior problems can be characterized by inattention, hyperactivity, impulsivity, non-compliance, right? Kind of being able to follow kind of the rules or expectations in different settings. Most times, right, these conditions occur together, right? It's not uncommon to have both anxiety and depression and behavioral difficulties. We see behavior problems as more common in that kind of 6 to 11 years of age, and then depression and anxiety become more common with increased age, right? And we were talking about that kind of the transition into adolescence.
When you were reading the behavioral stuff, I felt like you were reading my elementary report.
Yeah.
Wow. And that trend, so those top three things, anxiety, depression, behavioral, has it been that way for the most part? Because that sounds like that's not a trend.
So, I think these are three categories, although I will say that particularly anxiety and persistent feelings of sadness, we do know have increased in prevalence, or kind of how common these problems have increased even before the pandemic, and then really got exacerbated by the COVID pandemic. There's some big national data sets that show this feelings of anxiety and persistent sadness have been increasing in youth for a number of years, right? So these are common categories, but the commonness of them have been increasing.
Wow. I want to go to Dr. Swartz now. So we know we have a problem, but what is your approach to helping individuals, patients, especially who are resistant to treatment or even skeptical about the whole area of mental health care? How do you address that? What's your approach?
Well, one thing is to try to get people to understand that they can feel better. Now, I think the basic premise that we all have, the reason we're doing this is we want people to know so they can feel better. But if you're having a mental health issue and it's so private, you just think it's part of you. So I think that's a big step, is to say, I think you're going through something where we have treatment. Most of us change what we're doing when we think the change is going to lead to feeling better. And so it's outlining that, finding out how the person is feeling, what's problematic, and then explaining how treatment we think will improve that and how they actually will be in a better place.
Excellent.
And the whole, how do you get people to take it seriously? That's probably a 17-hour series, because we just as a society are still struggling to take mental health issues seriously, which, I'm a psychiatrist, I can't stand that, but it's a big issue. And so I think having somebody, your pastor, your mom, your dad, your grandmother, someone willing to go with you and saying, I hear them, you can feel better, let's do something about it, I think makes a big difference for young people. Coming to see one of us as a professional, we don't have that much sway. We're in general, kids are not saying, I hope I got to go to the doctor today, because that would be really fun, right there. Right. That is not where people are. And so I think having a champion that's someone they know, love, and trust, also there and participating, makes a big difference.
One of the things that keeps resonating with when I hear you speak is the importance of recognizing the need of the child, that there's a need for intervention. So I want to go to Dr. Seidel right now. And if recognition is important, what are some of the barriers that you see? And is skepticism one of those barriers?
Right. I think so. I think it requires both, acknowledgement from the patient as well as the family that there's a problem. And usually there's a mismatch when we see that either the teen is seeking help, and maybe their family does not perceive it as big of a deal as it is, or the risk of discrimination and stigma associated with it prevents them from getting care, or sometimes the opposite, the family perceives a big problem. They see external things, there's problems at school, and the teen doesn't perceive or doesn't have the insight, I think that's a big one. And I think prior negative experiences in the mental health system can impact them wanting to seek help in the future. Those are probably the biggest barriers that I see probably at work.
I was thinking, I'm the only man in this meeting today. But I think part of the problem is this masculinity that we project on our sons, especially when they show, because mental health is something we can, like you said earlier, if you break a leg, if something is broken, we know we got to take you to the hospital. Attaboy, we're going to paint your cast. This is a football wound. But if your mind is wounded, you're a Swartz man. You're a Seidel man. We're Reynolds men. We're battle men. Even as you watch kids grow up in football and they're not even allowed to cry, like stop acting like a girl. So that's a barrier for sure. If you're not even allowed to be hurt because it's considered something non-masculine, I know that's a barrier that we've got to overcome. I want to go back to skepticisms, to either Dr. Swartz or Dr. Reynolds. What are some skepticism that, if there's a skepticism that you see about mental health care, what are some of the skepticisms that you see that you all may have mentioned already, need to, highlight?
People think it's weakness. This basic idea that anxiety disorders are treatable medical problems, all the things that Dr. Reynolds talked about, they're all treatable conditions where there are people trained to recognize them and treat them. We don't treat weakness. But that's what people think. It's what you just, beautifully said. Toughen up, rub some dirt on it. Come on, keep going, right? Mm-hmm. And so this idea that admitting it is saying something bad about yourself. But combine that with an illness like depression, where part of the illness is that you feel terrible about yourself. You think you're weak. You think you're bad. You think you're a disappointment. So you have an illness that's twisting your thoughts. And so when someone says, I just don't think you're trying hard enough, and you say, you're right. I'm kind of a screw up. You're right. Okay. I accept that. That isn't someone saying, heck no, I can't breathe. Come on, I got to go to the hospital. People aren't saying that. The illness itself gets in the way of recognizing that you have a problem. It feels like you. No, this is how I am. So.
How do you think it's called laziness, or you just don't want to do anything? And then you hear the stories, of course, that father walked to school uphill both ways, which is impossible, barefoot in the snow. 60 miles one way to school, and we had to work on the farm and do our homework while driving a tractor. But is that also how it's labeled? Like you're just not trying, you're lazy.
I think that's really common, and for patients then to feel like I'm lazy. I like to tell patients I don't think anyone's lazy. I think we have lagging skills and unsolved problems, right? And part of what we're trying to do is to help with those lagging skills and unsolved problems, and that kids do well if they can, right? And that laziness is not my favorite term, right? And sometimes we need to be lazy. Sometimes we need to take some recovery time from our busy lives. So.
Wow. Dr. Swartz, I'm going to stick with you right here. What do you believe is at the heart of the matter regarding access to mental health care services?
Well, for young people, we just don't have enough professionals trained. There's studies that estimate we need, I'll get Dr. Reynolds to back me up here, but we need about 40,000 child psychiatrists in this country, and we have 10.
Whoa. You have 10,000.
There are 10,000 in the country, and it's the estimate.
You did say 10. I was like, whoa.
not 10, like we could double the number here, but there are 10,000 only. But think about that. That means we have a quarter of what we need, and that has become more of a crisis with the numbers that Dr. Reynolds was sharing, where she's saying, right, since before COVID, they were going up and they exploded in COVID. So what we need and what we have available for young people doesn't match. which is why we need colleagues who are pediatricians and are in the community and are therapists. And we're trying to put together a team with everyone we possibly can. But you have, when you think about getting someone what they need, first they have to see there's a problem. Their parents have to agree that there's a problem. They have to know where to go. There has to be someone there that can see them. They have to like the person enough to go back. It's a lot of potential problems in actually coming up with a really good working relationship between a young person and a mental health provider.
Wow. So we don't have enough people to help solve the problem. I want to come back to the COVID increase, because I want to see what you all think about COVID created it. It may be obvious, but I don't know the answer to that. And Corey, I haven't forgotten you. I'm coming to you in a minute. So what is it about COVID that increased the number of mental health patients or people with disorders that may not be obvious to someone like me?
I can start and then feel free to add in, but I think that kids were out of school for so long. School connection is a huge protective factor for children. So we lost our regular socialization. We lost adults getting a chance to say, hey, I'm worried about you, right? Kids were kind of pretty isolated in their home. We lost structure, we lost routine. I also think it's important to that families were really struggling during this time, right? We lost jobs, there was sickness, right? We lost family members. And so there were a number of huge stressors that really, I think, further compounded challenges, right? Kids were spending way more time online and on electronics, right? And not in in-person interactions, and doing things that can help them feel competent and in control of their life and effective.
And wow. I think the whole pandemic also, you're creating more anxiety because the whole thing is about, you're trying to isolate, you're trying to prevent deaths. On the news is constant, talk of all of the things going around surrounding the pandemic that I think also someone who's prone to anxiety, it naturally is going to worsen it when you're constantly hearing about something that can be anxiety provoking.
Wow. Do you think our world has ever reset from that? Just in general, I know this is not the topic. I don't think we've ever rebounded. Wow. Corey, you've been so patient.
Thank you.
We came to hear you today. Corey, tell us about your experience. And I want to, first of all, commend you for your work. As you said in your introduction, you've had experience with not just mental health disorder, but also substance abuse. And I'm so proud of you, because I call this turning your misery into a mission, which makes other people have an easier time of managing their problems, because whatever you survived, you have a roadmap for survival that others might need. So I just want to thank you, first of all, for your work in this space.
Yeah.
Having said that, my question to you is, what's been your experience, and what would you like youth who've been recently diagnosed to know about this matter of mental health disorder?
Sure. So I will say, just starting out, that a lot of the things that everyone's been talking about definitely held true for me in my experience. And I think one of the biggest takeaways from my personal experience is that, mental health and substance use, there are definitely environmental factors that can really impact who they affect, but they don't discriminate. I came from a stable 2-parent family. I think in my family, mental health just wasn't really talked about, because there wasn't anything to talk about until there was a problem. The other piece of that is that my parents were parents for the first time. I'm an oldest child. So they were just going off of the information that they had. But when my mental health symptoms really took root, I was an adolescent. I had dealt with some major transitions, like our family had moved away when I was in the 5th grade, and just going through like not only moving, but like the 5th grade to 6th grade transition and then into high school. I just didn't adjust well to it. And then a lot of the like behaviors I was having, my family thought were pretty normal for a teenager. They were like, it's normal for you to like want to stay in your room all the time. It's normal for you to not want to do your chores. But it wasn't until my mom noticed that I was self-harming that she actually was like, oh, this is a problem. And she went to the pediatrician, and that's when my, journey really started. We started out with talk therapy. I've been in talk therapy since I was 15, so 15 years. And I think starting out, as a youth, like you don't really understand like what it is, the goal of therapy is. Like a lot of the times we just ended up talking about problems like, why am I late for the bus in the morning? Why can't I wake up in the morning? Not like, why am I staying up until like 2, 3 a.m., can't sleep. I felt misunderstood a lot of the time. I love my parents, but they were also very much like, can't you be depressed and empty the dishwasher? Can't you be depressed and vacuum? Like, so it was really hard to explain, like, that I'm not just being lazy, like I'm having issues here. And so when I went off to college, I had my first hospitalization, and I was introduced to psychiatric medication. And then that, like, coupled with my substance use, things really got exacerbated for a while. I left school after a traumatic experience. And when I was 23, it was when I was finally able to enter recovery. I went to substance use treatment, and I really stuck to like the treatment plan that was provided for me. Other than that, like, I will say that my family has been the biggest support to me, even though they haven't always understood. And I think, like, the main thing I would want somebody who was newly diagnosed to know, especially an adolescent, is that there is hope. Like, it sounds corny when you're talking to younger people, because they're like, what do you mean? Like, this is my life. Like, I can't see past like tomorrow or this week. But yeah, I mean, I just couldn't find the other people like me who were dealing with what I was dealing with. I couldn't find the people that were on the other side of what I was dealing with, really. And that's part of why I do what I do. I'm just giving back what was freely given to me. And not always freely, like healthcare does cost money. But yeah, I mean, it's been a trial and error. And I hope that people who are newly diagnosed really just hold on and wait for those people who do understand and do like care to show up in their life.
When you were talking, I thought about the need, Dr. Swartz talked about this deficit of caregivers in this space, right? Quality psychiatrists need 40,000, got 10,000. And so we need the professionals, but I just think you're so critical to the success of this, because as a parent, I would want to hear what Dr. Swartz, Dr. Seidel, and Dr. Reynolds had to say, but I also want to hear what you have to say, because you lived as a child living with parents who were clueless, right? And what are we missing, right? In your language, it doesn't have, from I just think that's such an important piece. Am I making sense, y'all? Because she's got the experience to say, here's what y'all want me to vacuum, and I'm in here thinking about, do I even want to live, right? Hey, well, can you wash the dishes? Can you stop leaving a mess everywhere? And that's so critical. right? And it's not that as a therapist that the medical professionals won't bring that up, but hearing it from her, that lands different, right?
Yeah.
Because she's part of the culture who's lived through it. So when you do peer mediation, or what do you specifically call peer recovery coaching, what does that include? Can you take us into, like, without giving us, any private information, what's that kind of entail for you?
Sure. So I do a lot of one-on-one and group work. The groups are usually facilitated by a licensed provider, but the biggest aspect of my work is self-disclosure, to help sort of lay a good foundation for a trusting relationship. You just have more credibility with people on like that relatability aspect if you can say I've been through it. I also have to be open with people about the reality that recovery is not like predictable or linear, because a lot of people I work with, I would say, they are not always prepared for this to last for a while. And you can be really impulsive when you're younger too. So you're trying to make decisions to like fix things now. It's easier when you're older and you have experiences to kind of look back and be like, okay, I wish I would have like thought that through. So when I'm doing the peer support work, I can sort of set some goals with my participants. It's really important to involve them in their recovery pathway. Like self-determination is huge. A lot of people are telling them what to do, what's best for them, but I have to listen to what they think is going to be good for them. And then the listening part is the biggest part. Like I do a lot more listening than I do talking, and it's non-judgmental. I have to validate people and not just like jump to a solution. Sometimes we really need to just sit with what they're feeling and what they're going through. And then finally, navigating community resources, navigating the treatment options from like an experiential perspective, and encouraging them to advocate for themselves and express their needs to their family members and their providers.
Excellent. And again, I can't commend you enough for the work you're doing.
Thank you.
You're making sense out of your own pain and helping others with it. Thank you for doing that.
Thank you.
Let's go now. Go ahead.
Add something?
For sure.
I have to say, I've had so many individuals tell me that until they were in some sort of recovery group and they saw someone like yourself having success, having gotten through it, having done the work, having persevered and really gotten to a different place, they thought my talking at them wasn't the least bit good thing, that anything was going to help. And so it is so important. I think especially when people are in recovery from substance issues, they need to meet successes who have been down the path and can be there with them. And I'm very grateful, as I'm sure we all are, that you and people that have had this experience are so willing to share what's very private.
Thank you.
So true. Let the church say what? Amen. I think that's so important. And I want y'all to, if you can, look at the comments, especially Corey, all of you. If you look at the comments, people are really grateful for your work, each of you. Let's go now to treatment and medication. Since anxiety and depression are two of the tops with youth, I want to start with you, Dr. Reynolds, and you address this, please, from the lens of anxiety. And then Dr. Swartz, you address this question from the lens of depression. What are one or two examples of effective treatment plans for youth dealing with these mental health disorders? It's too late to help me with my behavioral issues, but let's help anxiety and depression.
Yeah. Great. So for anxiety with youth, I'm going to focus on the therapy part as a psychologist. That's the type of treatment that I provide. And the type of therapy that we know kind of has the most evidence to suggest that it's helpful is called cognitive behavioral therapy. And that approach focuses both on our thoughts and our behavior. And so really they're kind of different stages of treatment. We want to start by giving a lot of education. So helping the youth and their family understand anxiety, understanding that what it's like to be in fight or flight, right? What it's like to approach the situations that are eliciting such an anxious worry, right, for a child. The next step is really doing a lot of skills training. And so teaching the child relaxation, different kind of coping strategies. And then we move on to cognitive restructuring, which is one of our fancy terms to be identifying some of those automatic negative thoughts that can really serve to maintain anxiety over time, right? So we might think, if something bad happened today, it means something bad will happen every day, right? And so we have to identify those automatic negative, anxious thoughts and then begin to look for the evidence. It might not always be possible to stop those types of thoughts from coming, but we are trying to develop tools to be able to say, hey, I might be having this thought, but this is a thought or a feeling and not a fact, right? And beginning to kind of challenge some of those thoughts. And then for anxiety, one of the most important parts of treatment for the youth is what we call the exposure part of it. So is actually doing things that are making us anxious. And we do it within a hierarchy. So starting kind of lower on the hierarchy and increasing kind of the demands or the anxiety provoking nature of whatever it is. After the pandemic, we've seen a lot of children with anxiety about going to school, right, after the return from being virtual. And so thinking about a hierarchical approach to returning to school, we might start by just driving around the school building, going up and touching the door handle, right, spending 10 minutes in the school, 20 minutes, right, and increasing, right, increasing the exposure over time as the child is beginning to feel more competent. And like basically what we're looking for is when you're doing that exposure, we're looking for the anxiety to peak and then to come back down. And we're really trying to like retrain ourselves that you can do these anxiety provoking things. I also want to really emphasize that having parents involved in treatment is really important with youth. And so with anxiety, we want parents to be able to learn strategies to help manage their child's anxiety. We also want parents to be learning strategies to manage their distress, managing their child's distress, right? Because sometimes we can see those things really kind of serve to escalate and maintain anxiety. One of the biggest pieces as we can think about accommodation, right? And that parents are kind of over accommodating and it just serves to maintain anxiety over time. Now, we don't want parents to go full away from accommodation, but we want to do it incremental, just like we do with that exposure piece. And typically, depending on the severity or the duration or what type of anxiety, treatment can last kind of as short as like 8 sessions. I would argue is very short, but more like 20 sessions, right? Depending right on the condition and the patient's response to treatment.
Wow, great stuff. And that managing the parents' stressors so that they have even the space to deal with it. Some parents just don't. You're gonna have to go to school. I'm scared or not. I have to go to work.
Right.
So going in there, right? So yeah,
right.
That's big.
And helping parents know when maybe when their child is reaching out to them, it's terrible, come pick me up, right? That they can help them, coach them to use a coping skill or to reach out to trusted adults in the school to manage being there rather than going in and kind of swooping up, right? And kind of saving them from what's making it a challenging situation. Really you want to do that in collaboration with your child and their team, right? To say like, we're here for you and me picking you up is only going to keep this anxiety going, right? It's not going to help it get better over time. But sharing that as part of a goal versus like working together for this. Yeah.
Great. Dr. Swartz?
So for depression, I thought I'd talk about the things that everyone benefits from because the plans are very individual. there are some things everyone needs to do that have to do with structure and making sure that you're not engaged in negative behaviors. And then almost everyone would benefit from a form of CBT that's focused on the negative thoughts of depression. And then it's individual whether someone does or doesn't need medicine. So let me talk about each of those. Things that everyone should do. They need to sleep. Young people do not sleep. Sleep deprivation is terrible for depression. If you're sleep deprived, the treatments won't be as effective. You need to eat healthier foods on a regular basis, not only at dinner or something, nutty. Because young people, and you don't have much of an appetite when you're depressed, so this becomes more of an issue. Even if there's no eating disorder, just people don't feel like eating, so they don't. But then they're trying to do things that are hard and they have no internal fuel. They need to not use drugs and alcohol. And I know that young people will tell me it's the only relief I have from how terrible I feel, so I understand it. But there is a lot of evidence that alcohol, marijuana, and other substances actually have such negative effects on the brain that they worsen or sustain depression. So there are those things you're doing. You're changing certain behaviors. Many people engage in other behaviors. Corey was so kind to share her experience and get involved with self-injury. That somehow, I've seen people that when they're able to get control of that, the same treatment that wasn't working starts working. So they're doing certain things, healthier, making healthier decisions, having healthier behaviors. They're good for everyone. Everyone with depression has this distortion of thinking, so you just get so negative about yourself. There, the CBT, which Dr. Reynolds just beautifully described, there you're challenging the I'm a screw up, I'm a lousy person, no one wants to be my friend, I can't do anything right. And so those are the automatic thoughts. And so you're working with your therapist to say, wait a minute, maybe this is the depression talking, maybe I'm being too hard on myself, because that would cause you to make choices again that aren't positive. Whether medication is or isn't indicated is really individual, and a lot of it has to do with how long it's been going on, how severe are the symptoms, and if someone's having what is the most serious and potentially dangerous part of depression, which are thoughts about harming yourself, suicidal thoughts. So with really severe depression, it's sometimes all of those things together, but that's something we decide on a person by person basis. I will say that everybody needs a safety plan with depression. If you're having thoughts that your life's not worth living and you really don't think you want to continue, that you're thinking, I just don't think I can continue this way, you need to have trusted adults that you can reach out to. They're usually parents, but sometimes they're a teacher, the school nurse, a counselor, so that you have someone that can be with you to make sure that you don't impulsively act on thoughts that thankfully we're confident can get better, but in the moment you don't believe that they can get better. And so that's a other piece of a comprehensive depression plan that has to be there for everyone.
Outstanding. I know we're running up on our time and we got a lot more to talk about. So let's go to this question. Can mental health conditions be effectively managed without medication?
Yeah, depending on the person, often. But I also think people need to be open. We usually try the kind of treatment Dr. Reynolds was describing first. But if that's not successful, if our best psychotherapy is not successful, sometimes we have to reassess and say, do we need more? I would say with youth, that's the way we usually approach this. Or if things are really severe, or in a family that people have really benefited from medicine before and they've needed it to get better. Those are the things that go into decisions.
Are there any, I know this is a risky question, are there any natural supplements that you would say could be supportive, or maybe not, even if they're not replacements, could be used in addition to?
I feel strongly to make one comment about that. Mm-hmm. My big worry about natural supplements, some have a lot of the same active ingredients or have the same activity as medicines. But when people are using active supplements, they often have no one monitoring them. They don't know if things are getting worse. They don't know if they're sort of crashing into a much more dangerous place. So that's my big worry about it. I've worked with people that wanted to do that instead. I'm like, that's fine. We can try all kinds of things, but you want someone, your pediatrician, a therapist, a counselor, someone watching along with you, because that's often a do-it-yourself. We don't usually say, let's have do-it-yourself surgery. Let's do that.
I got you. Okay. Let's go to Dr. Seidel. In the emergency care space, what are some of the most prominent disorders that you're seeing in emergency care?
So, because anxiety and depression are probably the most common, we see a large number of youth suffering from severe anxiety, possibly causing panic attacks, which will bring them to the emergency department. That can be debilitating at times. We may see people who are feeling suicidal. We may see overdoses, both intentional or accidental, because people are feeling overwhelmed and have either done something impulsive or planned something, or they've turned to substances to try to fix how they're feeling. And then I think we didn't mention a lot, we may see some of the disorders that cause actual psychosis, where people may have hallucinations. They can be some of the more dangerous things. So people may be acting out. They may have lost touch with reality. And those are probably the most challenging, because there's not insight into the condition, and they can be, people may become agitated. And then I think I do disservice if I don't mention this. Two things. One is there's a lot of physical disorders that go hand in hand with mental health. I use the analogy that I race bikes, and before every race, I'm in the bathroom 1,000 times, my stomach's upset. It's clearly because of nerves and anxiety over the race at hand, but it's a real physical symptom. So we see a lot more belly pain, a lot more migraines, a lot more headaches, a lot more physical symptoms, because people keep the mental health part inside, and it may present in physical ways. And then I think a population we haven't talked much about, we see a large number of our LGBTQ plus, youth that may have less support, disproportionately present to the emergency department. And I think being sensitive to the fact that that's a high-risk population and making sure we have resources to support them is also very important, because the families are not always supportive. We would hope they are, but that's one of the challenges. Or they may not feel comfortable being open with the family. So they may be fully, keeping things to themselves. So that's probably, I think, an overview of things that I might see.
That's a lot. Since you mentioned resources, can you share some of those resources for emergency care that's available to people?
Yes.
The link or something? Website?
Yes. So maybe we can put out, I didn't prepare where I can put up an easy link, but I'd like to mention a couple.
You can actually join the chat, Dr. Seidel. You can actually put the information in the chat.
So what I'll do is I will mention a couple things first, and then I can add them while other people are going into the chat. But in the Howard County area, there is, Shepherd Pratt has in the Elkhorst location for ages 5 and up, kind of a crisis psychiatric urgent care, I think from 10 a.m. till 9 p.m. There's the Howard County Mobile Crisis Team that can be reached. I think you can even call 911 and request the mobile crisis team, but there's a specific number. There's a grassroots crisis intervention, which has suicide hotline, mobile crisis, emergency shelter. There's the 988 emergency number that can connect. And then there's things specific. So there's a national suicide prevention hotline. There's a trans lifeline for our trans youth who are struggling. Trevor Project has resources for the LGBTQ population. The National Alliance on Mental Illness. There's a lot of online support that you can look up. And the Howard County government has a website that lists a lot of these mental health emergency services that I would also refer people to check out. And I'll see if I can put some of the information. And then our emergency department, one of the problems with emergency department is people come expecting mental health care. Really, we hope to keep people safe while we're getting the right care. And so I think that's one of actually the disconnects, is that we may not be able to provide a lot of mental health care in itself, but the goal is to keep people safe while we try to get them somewhere that can provide the proper care.
That's great. And when you're considering those links in the chat, if you could expand beyond the Howard County area and and list some things in the other parts of the DMV area and our listening audience could benefit from. But when you need help, you go where it is. So we understand.
Okay.
Ashley Handel has a question in the chat, and she says, "Is it true that certain nutrient deficiencies, like a vitamin D, can increase the risk of mental health disorders?" Is that something anyone has an answer for?
It certainly is true that if you have severe vitamin deficiencies, it can contribute. Vitamin D is a little bit tricky because what we found out is pretty much everyone is vitamin D deficient now. So it's a little hard to know. There's certain B vitamins that can be quite dangerous. And so making sure that you're medically okay is often a part of the process when you're having an evaluation, that people are asking about other medical conditions. And I know, as Dr. Seidel was saying, when you go to the emergency room, they're making sure there's not something else going on. We don't want to tell you you're having a panic attack if you're really having an asthma attack, that kind of a thing.
Got it. Dr. Swartz, I'm going to stay with you. Let's talk about managing side effects. If somebody's on medication, and there's a term that you all call adherence of medications, we need that broken down in the layman's terms. So let's talk about those side effects.
We now say adherence because it sounds like someone's making a choice to do it. We used to talk about compliance, which means that they were doing what we wanted. You're going along with ours. I always say, when I'm teaching my residents, I say, everyone decides every day if they're an outpatient, if they're going to continue the plan or not. So adherence would be, I've made a decision to keep taking this medication. Usually you do that because the benefits outweigh the risks or the side effects. And so I think it is so important with everyone, but particularly younger people that haven't, by the time you get to be 60 like I am, you have aches and pains and this and that, you have to put up with some stuff. When you're younger, I think it's really hard, especially because side effects might change how you physically feel. That might change the kind of feelings you can have. Some people can feel apathetic. So I think the critical thing is for people to be honest with their providers about what they're experiencing, because there are so many options. And I don't think young people know that. Well, okay, if that doesn't agree with you and it's giving you an upset stomach, let's do something else. It doesn't have to be, well, this didn't work, I'm done. One other thing I'll say about medicine is that our medicines take time to work. So you start it and you have to get to a full dose for a month or two before you see the benefit. Mm-hmm. Young people are used to taking pain medicine and antibiotics. They are not used to some idea of a multi-week delay for benefit. So they start it, maybe they have some side effects and they have no benefit, and then they say, this isn't working. So a lot of education, a lot of working with someone and saying, this is what we hope to achieve, but you tell me if you're having problems because we can do something else. I think that's how to work together to get better adherence, meaning the person making the choice over and over again to stay in treatment.
That's great. And shout out Radio 1 for hosting and sharing this on all of their platforms today. It's so important. Corey, I want to go to you and ask the question, what would someone like you or a peer, what would make them not take their medicine or be committed to their treatment plan?
Yeah, so I also have personal experience with being non-compliant. I think for me, a big factor is not having it be a part of my daily or weekly routine. So for me, what that looks like now is having one of those little pill compartments or whatever with all the days of the week, right next to where my toothbrush is, so that when I get done, I can, do that and be done with it. Before, when I was younger, I forgot a lot. I didn't have all the executive functioning or organization to remember to do it, or maybe I would misplace it. So I would get to school and realize, oh, I did not take my medication today. So that, and then as far as therapy, The barriers for that can be like transportation, cost. For me, like it was, a priority thing. Is therapy the priority, or is there something else that I'd like to cancel and go do? Because when you go to therapy, you're not always feeling bad like that hour of the day or week. Um, so it's really easy to be like, I don't need to do this today. And then like tomorrow or the next day when you are in crisis, you don't have that resource available. Um, so yeah, and then yeah, I mean transportation and cost are really big ones that should be considered.
Yeah, I say like this: if you're healthy and you have an appointment, go get healthier.
Exactly.
You strengthen yourself to resist atrophy. The healthier I am, if I'm healthy, let's go get healthier. All right, ladies, we're going to talk about support and community involvement as we wind down. Advice for family and friends about how they can help support a loved one with mental health conditions. Quick 30, 60 seconds.
Find out where they can go and go with them.
Wow. Now that's mic drop. Apply that. Find out where they can go and go with them. Let me ask you on that, Corey. Would you have wanted your parents to go with you or at certain stages, or did you want to go alone to get help?
So my mom came with me to quite a few sessions, and sometimes I did want to be alone, but it was nice to have that check-in, and even just to have somebody who was willing to like wait in the car for me before and after. But with my dad wasn't really, he didn't really get therapy. He was like, if we're going to talk about something, you can talk to me every day. I did want him to go, and I had to ask, and it was really uncomfortable. So I think it, depends on the individual's preference.
All right. Dr. Seidel, Dr. Reynolds, let's go to this next question too. What can physicians and staff do to improve interaction when providing care to mental health patients?
So I think we can be more sensitive to their needs. It's a tough setting for us in the emergency department. I think making sure there's respect and that we're not perpetuating the feeling of discrimination or stigma that sometimes exists. I think that's probably the big thing. And I think sometimes standing up for patients when being the support if they may not have supportive families who can quite understand where they're at, trying to advocate on behalf of our patients, sometimes bridging the gap with them and their families to help.
Great. Dr. Reynolds?
Yeah, just add listening, validating, believing patients. And something that Corey said earlier that really resonated with me was this idea of having hope, right? Believing that things can get better. And I often think as providers, we need to hold that hope for patients when it's hard for them to believe that anything can or will change. And so really bringing that to the session, things can and will get better.
Awesome. Corey, there's a question in the chat. You can join. You can actually, I'm sure you can answer that in the chat for Lakeisha Swan. I know we're down to less than 2 minutes. Any final thoughts, particularly around what do you want those in the community, want the community and those in the healthcare world to know about mental health? That's really Corey's question, but any final thoughts from any of you around things you didn't get to say or things you want to say right now as we conclude?
We can't just say mental health matters. We have to act like it actually does. And people with mental health struggles deserve respect, understanding, and care.
And I'd like to just comment that I think, we're sitting up here on a panel, but mental health is so prevalent. If you go to whether you're a physician or your therapist, many of them may struggle with mental health things or have family members that do. It really spans the entire world. So this isn't, I don't think we're speaking of it and immune from it. I think whether it intimately affects us, not just in our professional life, but almost all of us are affected even in our personal lives by it.
Dr. Swartz?
There's hope, so get help.
Dr. Swartz is dropping, but you must be on. She drops the little Twitter statements. I love it. Dr. Reynolds.
I don't think I can say much more than that. I agree. There's hope, so get help. And we know things can get better, right?
Hey, excellent. Well, I want to thank again Radio 1, Johns Hopkins Medicine, Howard County Medical Center for today's Youth Mental Health Equity Forum. Thank you, Dr. Reynolds. Thank you, Dr. Swartz. Thank you, Dr. Seidel. Thank you, Corey, and thank all of you who've joined us. Please share this link with someone. They can watch this and get not only important information, but access to links and phone numbers that can help them when they need it the most. We're going to leave you now, but we pray that everybody will be well. God bless you.